Welcome to Roadmap to Residency. Hello everyone, I'm your friend Abhiraj. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So here we have, compared to other forms of thyroid disease, which of the following findings would be most specific for this patient's underlying pathophysiological process? So the question is asking us about one of the clinical feature in comparison with the other thyroid disease that will be present in this patient. Now let's read what is the patient all about. So we have a 44-year-old man who comes to the clinic due to increasing fatigue, trouble sleeping, and palpitations. He has lost 9 kg over the last year despite eating well. The patient says he's under a lot of pressure at work but cannot think of any other precipitating factors for his insomnia. He has no other medical problems and takes no medications. The patient does not use tobacco, alcohol, or recreational drugs. His mother has a history of a thyroid problem. Blood pressure is 140 upon 80 millimeter of mercury, and pulse is 108 per minute. On physical examination, the thyroid is diffusely enlarged, and his serum free thyroxine level is elevated and TSH level is decreased. Okay, so he is found to have positive assay of thyrotropin receptor antibodies. Compared to other forms of thyroid disease, which of the following findings would be most specific for this patient's underlying pathophysiological process? So if you just decode this question, we have 44-year-old man who have features of fatigue, trouble sleeping, and palpitation. So he has heightened emotions. Okay, he has uh, heightened activities. So he has also lost weight. So he has also high BMR that is happening in spite of eating well. And also the patient has a high blood pressure, 140 upon 80. The thyroid is diffusely enlarged, okay? And also the free thyroxine level is more than the is more than the normal, and TSS level is decreased. It means that this is a primary thyroid disorder, right? Because the TSS level is decreased, the T4 is itself increasing in the presence of decreased TSS, means this is a primary thyroid disorder. If you can just see the previous video where we have explained how primary, secondary, and tertiary thyroid disorders are classified, you will have idea about this one. Now, we know that this is the primary hyperthyroidism by now. Now, what sort of hyperthyroidism is it? So here you can see in the question we have thyrotropin receptor antibodies, which means this is an autoimmune condition. So this may be Graves' disease, right? So what will be the skin? What would be the finding that is present in this patient? So atrial fibrillation, decreased bone mineral density, heat intolerance, tremor of outstretched hands, and skin thickening and induration over the skin. So the patient has symptomatic hyperthyroidism with elevated serum free thyroxine and suppressed TSH levels. The most common cause of hyperthyroidism is Graves' disease. However, hyperthyroidism can also be due to other processes such as toxic adenoma, toxic multinodular goiter, and thyroiditis. Now, this patient's positive serum assay for thyrotropin receptor antibodies confirms the diagnosis of Graves' disease. Now, these antibodies bind and activate the TSH receptor, causing increased release of thyroid hormone from the thyroid gland. So the defect is at the thyroid gland itself because the antibodies which binds on the TSH receptor and which stimulates the thyroid gland to release the thyroid hormone, which is responsible for the general symptoms of hyperthyroidism. Now, the TSH receptor is also present on the fibroblasts and adipocytes in addition to the thyroid epithelial cells. And thyroid dermopathy is caused by the stimulation of fibroblasts by these antibodies, by these thyrotropin receptor antibodies. And this leads to the excess production of glycosaminoglycans and adipogenesis. And this leads to the induration and thickening of the skin over the cells. And Graves' ophthalmopathy is also a similar kind of pathogenetic mechanism. So Graves' ophthalmopathy occurs in a similar manner with expansion of the retroorbital tissues, displacing the globe forward, causing proptosis, right? Now, because these processes are directly related to the thyrotropin receptor antibodies, they have high specificity for Graves' disease. Now, here you can see the skin thickening and induration over the skin due to the Graves' disease that is there. And now, how does the Graves' ophthalmopathy develop? So, whenever the TSH receptor gets stimulated, then these TSH receptor antibodies can also be carried up by the antigen-presenting cells, right? And now these antigen presenting cells, they just uh, act on the B cell and they produce the anti-TSS antibodies. Okay, now these antibodies go and act on the TSS receptor. So this is how antibodies produce. These are the autoimmune antibodies. Okay, so when the TSS receptor acts as an antigen, right? When the TSS receptor acts as an antigen, then it is carried off by the antigen presenting cell due to any cause. Okay, due to any cause, these TSS, this normal TSS receptor may also start acting as an antigen, and these antigens are taken up by the antigen presenting cells and they are carried up to the B cell, and the B cell produce anti-TSS antibodies. Now these are autoimmune antibodies. Now these autoimmune antibodies, will go and act not only this TSS receptor but also the TSS receptors in the orbital fibroblast, right? And when it acts on the orbital fibroblast, then that will lead to the differentiation or adipogenesis, fibroblast proliferation, and hyaluronic acid synthesis, and these all lead to the expanded orbital muscles and adipose tissue, causing Graves' ophthalmopathy or proptosis. So very simple, TSH receptor, when it starts acting like an antigen, antibodies are produced. These antibodies go and act on the receptor, and then all the processes are heightened, leading to Graves' ophthalmopathy. So what is Graves' disease? We just discussed in short. So it is the most common cause of hyperthyroidism, and the thyroid stimulating immunoglobulin stimulates the TSH receptors on the thyroid, dermal fibroblast, and orbital fibroblasts. Right? Now, the activation of T cells will lead to the lymphocytic infiltration of the retroorbital space, and it will lead to the cytokines infiltration, and then there will be the fibroblastic secretion of glycosaminoglycans, and then the osmotic muscle swelling, muscle inflammation, adipocyte count increase will be there, as we all discussed earlier, leading to exophthalmos. Now, the histology of Graves' disease is that you can see tall, crowded follicular epithelial cells and scalloped colloid. So this is the histology of Graves' disease. Where you can see the uh, normal thyroid gland, all this is smooth colloid is there with follicular epithelial cells lining here. But here you can see in Graves' disease, there is a scalloping, right? There is this finger-like segmentation happening inside the colloid matrix, and that is called the scalloping of colloid. And also the follicular cells have become tall and they have become crowded. You can see how these are separated and these are crowded. These are tall, crowded, and follicular cells from a papillary projection. So what you can find is scalloping of colloid. Okay, number one, this the colloid normal structure, number morphology is disrupted. There will be scalloping of colloid, number one, plus there will be tall, crowded follicular papillary projection. Now, what are the clinical features of thyroid storm? So what actually precipitates thyroid storm is thyroid or non-thyroid surgery, some trauma or infection, some viral infection can cause thyroid storm, and some acute iodine low. Okay? If there is iodine contrast that is given to the patient, then that can cause thyroid storm. Now, the clinical features of thyroid storm is high fever, tachycardia. Consider everything that is due to the increases in thyroid hormone. Okay, thyroid storm means there is a storm of thyroid hormones. So there is high fever, there is tachycardia, hypertension, congestive cardiac failure, there are arrhythmias, agitation, delirium. So everything is heightened. There is a goiter, there is jet lag, there is tremor, the nausea, vomiting, diarrhea, and jaundice. So all the functions of the body or the systems of the body are heightened, and that will be just the symptoms of thyroid storm. So thyroid storm is nothing but just the acute increase of thyroid hormones due to any cause. So what are the symptoms of Graves' disease? So there are some, so the symptoms are divided according to the system. That will be easier for you. So general symptoms will be heat intolerance, weight loss, and sweating. It is because when the thyroid hormone is increased in X-rays, you know that the thyroid hormone regulates the BMR. So when there is increase in the thyroid hormone, there is increase in the basal metabolic rate. There will be increased heat production. So the patient will have heat intolerance, will have weight loss, and will have sweating. So eyes, you can see due to the Graves' ophthalmopathy, there will be lid lag, proptosis, and diplopia. In the skin, there will be hair loss, there will be infiltrative dermopathy, the pathophysiology we just discussed about. And the cardiovascular system, the heart will be tachycardic, there will be hypertension, and there will be atrial fibrillation because of the thyroid hormone. The heart rate increases. We all know that, right? Now, on the nails, there will be clubbing and there will be oncolysis. And in the endocrine system, there will be hyperglycemia, hypercalcemia, bone loss, menstrual irregularities. And in the gastrointestinal, there will be diarrhea. In the neurological systems, there will be tremor, hyperdysplasia, proximal muscle weakness. So whenever you try to remember the symptoms of the Graves' disease, always remember you can easily differentiate this is a Graves' disease because all the systems are overacting. Okay, all the systems are overshooting because of the increased level of the thyroid hormones that is there. Now, also some of the Graves' eye disease symptoms will be swelling around the eyes, bulging eyes, gritty sensation in the eyes, pressure or pain in the eyes, light sensitivity, photophobia, double vision, and some cases there will be a vision loss. So this is just a brief review sort of the Graves' eye disease symptoms. Now, so whenever we talk about thyrotoxicosis, there are thyrotoxicosis with normal or increased radioactive iodine uptake and thyrotoxicosis with decreased radioactive iodine uptake. So with increased or normal RAIU are the Graves' disease, the toxic multinodular goiter, and the toxic nodule. Everything else is thyrotoxicosis with a decreased radioactive iodine uptake. So we have the painless or the silent thyroiditis. We have the painful decurrent thyroiditis. We have amiodarone-induced thyroiditis, the excessive dose of levothyroxine, struma overi, iodine-induced, and extensive thyroid cancer metastasis. Some of the questions will mention you about the radioactive iodine uptake, and then you have to have these differentials in mind about which conditions causes increased radioactive iodine uptake and which condition causes decreased radioactive iodine uptake. Now, what are the complications of the Graves' disease treatment? So we will talk about the treatment and the complications at the same time. So the first drug, obviously, are the anti-thyroid drugs because we need to stop the production of thyroid hormone. So the drug that we generally use are the thioamides, okay? And these causes agranulocytosis, which is the most common and most serious side effect. And you need to monitor agranulocytosis time and again if you are doing the thioamides treatment. And if we are using methimazole, then that will cause the first trimester teratozine and cholestasis of pregnancy. So you cannot use this drug in the first trimester of pregnancy. Talking about profile thiouracil, okay, it can cause hepatic failure and it can cause ANCA-associated vasculitis. So the question may mention you that the patient has Graves' disease, he took some medication, and now he is having vasculitis sort of symptoms. What medication did he take? The patient took propyl thiouracil, right? You know, the another treatment is the radio iodine ablation. So it can cause permanent hypothyroidism and it can cause worsening of ophthalmopathy and possible radiation side effects. Like whenever you just pass radiation in the neck area, then the radiation can also pass in the chest area, and that radiation will cause radiation induced restrictive cardiomyopathy, right? Now, some of the surgeries are there. So we just remove the thyroid gland hole that can cause permanent hypothyroidism, risk of recurrent laryngeal nerve damage, and risk of hypoparathyroidism because the parathyroid glands may also get removed while removing the thyroid gland. Now, let's talk in a little bit about neonatal thyrotoxicosis. So, the pathophysiology is the when the transplacental passage of maternal anti-TSH receptor antibodies occur. So, for example, the patient has autoimmune antibodies, the mother has autoimmune antibodies, and when these autoimmune antibodies just passes through the placenta towards the fetus, then these antibodies will bind to the infant's TSH receptor and cause excessive thyroid hormone release. So, the same mechanism that is happening in the mother, it is just that the baby is not producing the autoantibodies. The autoantibodies are transferred from the mother towards the baby, and then the same effect will be shown in the body itself. Now, what will be the effect that will be there in the baby? So the baby will have warm or moist skin, tachycardia, poor feeding, irritability. There will be poor weight gain. There will be low birth weight or preterm birth because the baby's BMR is too high that the baby is already losing weight. Now, the diagnosis if the maternal anti-TSH receptor antibodies are more than 500% or more than 5 times than normal, then it is the sure diagnosis of neonatal thyrotoxicosis. So the treatment is it can be self-resolved within 3 months. because the baby is not producing the autoimmune antibodies, right? It is from the mother. So whenever the maternal antibodies are disappear, okay, when the maternal antibodies are all over, then it will self-resolve. But by that time, we will just give methimazole and beta blocker. Okay, methimazole will be anti-thyroid, and the beta blocker will just mask the symptoms. Thank you for watching. We will again back in the next one with on the super duper concept. Thank you all.